Good morning, this is Dr. Mark Sell of the YouTube channel Therapy for the Heart. This is the 10th talk in a series on what makes for a good psychotherapy session, and today I'm going to address the treatment of drug and alcohol addiction, focusing on countertransference. For the definitions of these terms, you can refer back to talks 1, 2, and 3, where I talk about countertransference in detail and transference. It's very difficult for people to stop alcohol or drug use. For people addicted to drugs and alcohol, self-medication through substance use has become a way to soothe the self when self-soothing mechanisms have not been developed in early childhood. For instance, a child may be left crying for a long period of time without being picked up, or children are often scolded or abused or humiliated on a consistent basis, and these will definitely interfere with self-soothing mechanisms developing in the child. The source of these disturbances have often been elaborated on in the beginning talks of this series, so I hope you can review them. It's important to keep in mind that as much as someone may want to stop their drug and alcohol use, there is a wish not to stop. It makes sense that this ambivalence exists. Alcohol or drugs have been a way to adapt to stress and conflict. It's a friend during loneliness, a way to feel comfortable in social situations. Sometimes the shy can become the life of the party, and a way to feel potent instead of impotent, for instance, in crack use. Why give that up? In our work, we have to suspend our ideas about what we think is the best treatment approach and listen to what the person wants as they struggle with their drug and alcohol use. If we listen and investigate, we gain a lot. Referring back to the videos, you can see that I've stressed that children are often not heard as to what they feel, think, and want in life. Here's an example of a treatment being imposed on a client. A person comes in to see me and they talk about being in treatment and their former experiences with the therapist. They were very discouraged because the therapist insisted that this patient go to AA in order for the therapist to work with her. Apparently, for whatever reason, the therapist didn't understand the patient's history, but this patient came from a family group which was affiliated with a group that was very abusive and demanded very rigid behavior and were emotionally abusive to the family members. So to go to AA for this patient, it meant going to this kind of group, and it was experienced as a cult. Even though AA is not a cult, it can be experienced like that, especially with a person who has this kind of history. So I said to her, what would she like to do? And she said, well, she'd like to work with me, but did not want to go to AA. And I said, that's fine with me. We'll work together and see how it goes. So she stayed with me. She made some advances. She took some steps back, as is usual in treatment, and but stuck with it. And eventually, she went on to go to AA on her own. Interesting. So she continued with me. She worked with me and attended her AA meetings and got better and really improved in her life. Substance users are often plagued with feelings of shame and self-attacks. Shame and self-attacks often plague most people, but with substance users, shame may be more predominant because of the embarrassing and abusive behavior of addicted family members towards their children. That often happens. They'll be embarrassed in front of neighbors, and the caregiver's drinking feels like then it's a reflection on them, that there's something wrong with them because of the way their caregivers are behaving. Pages are stuck. Regarding shame and self-attacks, if you have not done so, go to the talks 1, 2, and 3 on this channel and review how the internalization of self-attacks results in depression, psychosomatic illness, and thought confusion. As far as treatment approaches, the abstinence-only programs like AA are predominant. The goal is total abstinence from all drugs or alcohol. I will discuss harm reduction in a separate talk. I have a fondness for AA and how it's helped many people because my mother was an alcoholic. And going to AA saved her life and mine. She was really struggling with drinking. It was interfering with my life, with the family's life. And finally she got help. And there was a clubhouse we used to go to up in Albany. And there was I think I mentioned this before, but I'll mention it again. There was a guy named Pop Johnson. And you'd walk into this room. It was a living room, and very comfortable couches and chairs. And there was a kitchen there. And he used to make a meal every day for anybody who wanted to eat, and you didn't have to pay anything. You could throw in $1 or $1 or whatever, but it was such a friendly environment, and all the AA people were very, very welcoming to me. And sometimes I would go with my mother to help another alcoholic, and she would bring a bottle with her in case they had DTs. So that was interesting to me, and they can't do that anymore, but that's what they did back in the day. The 12-step programs like AA and NA, they counteract the feeling of loneliness and shame because there are other people in those rooms with similar problems, all talking about similar things. That reduces shame, helps one feel less alone. And for instance, things like the coffee after meetings is a way to socialize when socialization is not so easy when people are not drinking. Each meeting has its own character, by the way, so if people are turned off to one meeting, they can go to another meeting and find a way to hang their hat someplace where they feel comfortable. One major problem with the abstinence-only program is due to expectations. When the expectations of the client and the therapist are very high, as in abstinence-only programs, there is a danger that both client and therapist will feel very frustrated and experience feelings of failure when they can't meet those expectations. The failure rate of treatment programs in general, and also AA and 12-step programs, is very high. It's very difficult to work with, help people with drug and alcohol use, so that's understandable. A therapist can easily feel ashamed, impotent, helpless, self-critical, and angry, or give up on a patient. When there is a countertransference resistance, the therapist is unaware of his or her feelings. Then the therapist is unable to help and needs therapy and or supervision. If you watch talks 8 and 9 for a detailed example of how I become stuck with the patient because of a resistance I had, that becomes very clear. It's a good example. Dr. Spotnitz talked about the source of countertransference resistance. Therapists need not to feel hate or anger, need to be liked, need to be right, and need to be good are often the source of countertransference resistance. And these are very important for the therapist to pay attention to these feelings if they can and resolve them. After listening to 2 of my videos, again talks 8 and 9, just recently a woman wrote a comment on the channel and said when she heard what she heard helped her because I spoke openly about my feelings about my patient, talked about how they interfered with treatment when not understood, and talked about how the treatment became unstuck as I became more aware of my feelings and resistances. As a result, she was able to extricate herself from a very destructive relationship she had with a therapist. Several women, by the way, have come to me in a terrible position because they had erotic, affectionate sexual feelings towards their therapist, which they couldn't talk about. And the therapist, for whatever reason, was not able to help them. And sometimes it is very difficult to help somebody talk about such feelings. But I was very moved by them because they really could not remove themselves like this woman did on watching the tape from the relationship. And also they couldn't speak of the ideas that they had that the therapist had a problem. They couldn't talk about that, so everything was blocked. And that's not an uncommon occurrence. Because countertransference reactions exist in all treatments, as part of my therapy training groups, I facilitate a countertrans group, also called a transference resistance group. You can find a link for the information about this group and dates and fees, etc. Below this video. Those who have watched my videos know that I gained my experience working with this kind of group through over 15 years of doing a group like this with Dr. Gerald Lucas. He was a good trainer. In this group, therapists are encouraged to say everything that is on their mind. Saying everything as much as humanly possible, and I say humanly possible. Free association is a task to work on, but it's very difficult. But if you work on it, you'll become stronger and better. It frees up the therapist. We talked of shame before. Talking in a group, in this countertransference group, is a way to work through shame. Being part of a group also makes one feel less alone, and makes it possible to observe transferences in the group. And transferences are ubiquitous. They always are there to observe and learn about. People feel that the group is a safe place to be because they're not going to be judged for what they feel or think. Participate in this group, though, is a very difficult thing for therapists, because therapists, for some reason, have an idea that they have to work through all their problems, or they shouldn't have problems, and that's a feeling. If you think about it, of course, everyone's human, so you're going to have a lot of feelings and problems and experiences. As long as they don't interfere with your work with the treatment, then it doesn't matter how you feel, as long as they don't interfere and do harm to the patient. So if we have the courage to speak freely in a group about ourselves, then we can help our patients. If we don't have the courage to do that, how can we help patients find that courage? I will give an example of how the group works. One group member was missing for a few weeks, and I had the habit of reining her in because she wanted me to do that, because she had some fears of being in the group. So I called her to come in, and she came in, she talked about it, and the reason why she missed a few sessions was that she had sexual feelings toward the patient. And when she came in and talked about them, she understood that other people, because that opened up the whole group to them talking about their embarrassment, about talking about their sexual feelings. And so she got to feel comfortable, and in her work in the group, she was able to then go to her patient and listen without being uncomfortable, or at least not letting her discomfort interfere with her listening to her patient. Aggression is part of the problem when treating substance use. Substance users, when faced with a conflict over whether they are going to drink or not, often experience a feeling. In my experience, they feel often they have this reaction. Well, when they're about to take a drink or a drug, that who cares? And will drink or drug at the person who is experienced as uncaring in their life. It appears as self-destructive, which it is in part, but the hidden motive is to hurt the person initially responsible for the emotional damage done to the patient. It's called the narcissistic defense, which I've also referred through continually through the talks. For example, a woman I was treating on the way to a session had the idea that she wanted to use drugs to tear me down, ruin everything, ruin the treatment, because of a hurt she experienced with me in a previous session. That day she did not use, because over a 2-year period I helped her gradually, in time, when she was ready, express and experience her feelings of anger towards me and disappointment. By the way, the mistake that I made, the hurt that she felt, was indeed due to an omission on my part, a mistake that I made. And then she came in and was able to tell me about it. Then she also started to say, well, I know it's not my fault, not your fault, Dr. Sell, it's my fault. I wasn't paying attention. I said, no, I was really preoccupied at that time, and that moved her, because she said my father never would have took responsibility for his participation in our relationship and what he did wrong. So that was very helpful for her, and she stopped using drugs and continued treatment with me, and improved in all aspects of her life. When a therapist does not help with eliciting negative feelings, patients will act out on the negative transference and suddenly leave treatment. You've had that experience before if you're listening and you're a therapist, I'm sure. If you can help a person express their negative feelings along the course of treatment, you'll be less likely caught off guard by a patient suddenly quitting treatment. Modern psychoanalysis, a la Dr. Spotnitz, Dr. Hyman Spotnitz, has techniques to elicit these feelings. My patient did not stop treatment, as I said. She continued and made a good recovery. This is not to say that helping a patient to stop is easy. I've had my share of treatment failures. Last but not least, studies have shown that prejudice towards substance users exists in the helping professions, and if this exists, it's going to affect the outcome of treatment. That's pretty obvious, but there is prejudice, and it exists among psychotherapists, psychoanalysts, counselors, and it exists. Up until the study that I read was a fairly recent study, a very inclusive study of prejudice. So, I want to thank you for listening to this 10th talk. I hope to have another one soon, and if you like the channel, please press the like button on the screen, and if you have a Gmail account, you could subscribe to YouTube, and then you'll get all the videos uplifted automatically to your channel. And if not, you can always then you can write and comment and make comments, and that's very helpful to me because I get an idea of how people are reacting to the videos. Very important. And but if you don't get a YouTube channel, you can just remember Mark Sell. Just enter that in YouTube and you'll find all the videos. And I appreciate your listening. I want to thank you again for tuning in today. And I'll be signing off now. Thanks again, Mark Sell. Bye-bye.